About 90,000 patients in the UK have a proximal hip fracture every year. Over two-thirds of these patients are over the age of 65 when they have their injuries. And on average, a patient spends about 22 days in the hospital. The Office for National Statistics from the UK suggests that by the year 2033, the proportion of patients over the age of 65 is likely to increase dramatically. This obviously would translate into a higher proportion of patients with fragility hip fractures. The cost of these injuries amounts to nearly $2 billion to the National Health Service of the UK. Mortality associated with these injuries remains high worldwide. Recent meta-analysis work has actually shown that the average pooled mortality could be as high as 13%. One-year mortality ranges from 19 to 33%. 1 in 3 hip fracture patients is unlikely to survive 1 year. So our study was aimed at identifying the 30-day mortality rate at our institution to find out what these patients were dying of and to determine if a delay in surgery was associated with a higher mortality in our cohort. In doing so, we hoped that we'd be able to predict the potential predictors of early mortality in these patients. So it was a retrospective review, and we used the UK National Hip Fracture Database as our main data source. The study was conducted in collaboration with our information governance team, and we included all patients that underwent hip fracture surgery in a single fiscal year. We excluded any patients that died preoperatively and any erroneous or duplicate entries in the database. We were finally left with a cohort of 467 cases that underwent surgery for the study. Statistical analysis included descriptive analysis of the 30-day mortality rates and their causes, and we also undertook univariate analysis to find significant differences between people who died within 30 days and those who survived. We then used all significant parameters and entered them into a backward stepwise logistic regression model to find out what the most significant predictors of mortality were. So our 30-day mortality rate amounted to 7.5%. 35 of the 467 patients died within 30 days of their surgery. This graph shows the cumulative mortality over the 30-day period. And as you can appreciate, it's almost a straight line, which means that patients were dying at regular intervals between the first 30 days. What was also interesting to note was that all deaths within the first 72 hours of surgery were due to acute myocardial infarction. When looking at the demographics of these patients, we noted that patients who died within 30 days were significantly older than those that survived. But there was no difference in the gender distribution or the ASA grade of these patients. When you look at the causes of death in our cohort, we found that pneumonia was the most common cause of death, amounting to more than 37% of deaths, followed closely by acute MI. Interestingly, if you combine the effects of pneumonia and sepsis, then you could infer that more than 50% of the patients in our cohort died of infection. I grouped the patients into those that had time to surgery within 48 hours and those that had a delay of more than 48 hours, and found that there was significantly higher mortality in the cohort that had a delay in surgery of beyond 2 days. When looking at comorbidity data for these patients, we found that there were certain comorbidities that were of higher proportion in patients who died early. These were dementia, cardiac disease, COPD, and renal dysfunction. We did not find any significant difference in any other mortality, any other comorbidity that we checked for. We also found that there was a significant difference in that patients who survived beyond 30 days were more likely to be admitted from their own home or their own residence. In terms of walking ability, people who died within 30 days were more likely to be wheelchair-bound. The preoperative HP was significantly lower in those who died early. But there was no significant difference in the fracture type, in the implant used, the post-op HB, the mechanism of injury, or the type of associated injuries in these patients. On multivariate analysis, we found that the 3 most significant predictors of mortality were time to surgery more than 48 hours, cardiac disease as a comorbidity, and admission source other than a patient's own home. We also interestingly found a moderate correlation between a previous history of cardiac disease and patients that died from acute myocardial infarction. In summary, patients who died within 30 days were older, they had a lower pre-op HP, they were unable to mobilize independently, they were more likely to be admitted from an institution, have a delay in surgery of more than 48 hours, and a higher prevalence of certain comorbidities. When you compare our figures to those of the UK National Hip Fracture Database report for 2011, this shows a decreasing trend in 30-day mortality year on year. Our figures for 2009 are at 7.5%, which are conservative compared to the national figures. The British Orthopaedic Association suggests that all medically fit patients should have surgery within 48 hours of admission, and this is why I chose 48 hours as the cutoff for our patients. Meta-analysis work has also shown that delay in surgery beyond 2 days is likely to increase mortality in excess of 40%. There have been prospective studies which have suggested that pneumonia causes a 5-fold increase in mortality after hip fracture, and our study agrees with these findings. In a retrospective study with a large number of hip fracture patients, they have shown that acute MI occurred in 14% of patients within 7 days of surgery. And what's surprising is that 75% of these patients were asymptomatic, which perhaps tells us that we should be maybe checking cardiac markers in these patients post-operatively. We recently published this in the JBJS issue of May 2012, where we've shown that pneumonia was also identified as the most common cause of readmission within 28 days of surgery. And perhaps these patients have active clinical problems at discharge and then get readmitted with the same problem and die of it. The Nottingham Hip Fracture Score is a scoring system used to predict early mortality and has 7 factors. We've shown that our study is similar in some respects, but we did not find any significant difference in the sex distribution or the presence of malignancy. We did, however, have an additional variable, such as the time to surgery, which the Nottingham Hip Fracture Score did not include. So in summary, our limitation of the study, it was a retrospective study. We relied on ICD-10 codes for comorbidities, and the primary causes of death were collected from death certificates. Based on our findings, we suggest a multimodal approach, including the assessment and optimization of cardiorespiratory function, perhaps checking cardiac markers in high-risk patients, prompt intervention for any signs of cardiovascular compromise or infection post-operatively, and to minimize a delay in surgery beyond 48 hours. I thank you for your time. This possibly has implications for the best practice tariff as well.